what we now know is that the connection between our nutrition and our brain and our mental health is significantly stronger than the connection between medications. But I was faced with new information and new data and new research, and it's ever growing. Our team is constantly studying what are the foods that will actually specifically help the brain heal from addiction, in an acute state, in this residential setting. So it's a constant search.
Hello, I am B. Reeves with New Waters Recovery in Raleigh, North Carolina. Welcome to our weekly podcast, Finding New Waters. Our goal in creating Finding New Waters is to provide a resource for families to help navigate the complexities of supporting a loved one struggling with substance use or mental health. When we find ourselves in crisis due to one of these issues, most people have no idea where to turn. We hope to shed some light onto what is often the darkest hour for many families. Thank you.
All right, guys, thank you for joining us today for another episode of Finding New Waters podcast. My name is Justin McLendon, Chief Executive Officer with New Waters Recovery, and I'm joined today by Dr. John Dyben of the Hanley Foundation. Dr. John Dyben is the Chief Research... Oh, my God. Say it for me, John. I apologize.
Chief of Research and Innovation.
There we go. I knew I was going to mess that one up. Dr. Dyben is a seasoned professional. Been working in behavioral health for a number of years, and also has been with Hanley, the Hanley Center in Florida, in Palm Beach County, Florida, for a long time. And I don't want to do you any disservice. So, John, maybe you could take a couple of minutes to tell us a little bit about that. What's the story? I know you've been in the field for a long time, ordained minister, and I will even say some bias here in this podcast. John has been a big mentor for me in the past, and have a massive amount of respect for this man.
And that respect is very mutual. Yeah, I always start by saying I've heard it said that really messed up people either go into the field of ministry or mental health, and I did both. So my dual diagnosis is that I'm both clergy and clinician. I started my career out in past vocational pastoral ministry. But it was in seminary that I got my initial clinical training, and I always was doing counseling was always a big part of the work that I did. I eventually left church ministry and found that wasn't really where I was supposed to be, and I spent the early parts of my career after that in children's mental health. So I worked for Boys Town. Some people are familiar with Father Flanagan's Boys Town, and they have sites across the country. And I worked in therapeutic foster care, and eventually, at a pretty young age, was the director of emergency adolescent services. So I ran an adolescent shelter on staff secure detention for Central Florida. And so the one thing, really as a therapist early on, I knew that I was going to do all my life, working with kids and families. And the one thing that I was never going to do was adult addiction. That was just work I never was going to do. So I've been doing that nonstop for 22 years. And the past, this July will be 20 years at Hanley Center. So I actually came to Hanley as a chaplain, to be the chaplain, which is kind of really the combination of those clinical and spiritual trainings. Eventually, I got that seminary degree, got another master's in marriage and family therapy. Eventually, I started running programs, and so I got another master's in business management. And one of the things I love to talk about is I've always been really interested in systems. And so I was introduced to the discipline of health science and specifically epidemiology, and I fell in love with it. And so my doctoral background is a doctor of health science. And really it's studying epidemiology and public health in a way that looks at what are the things in our systems that contribute to us being healthy, and that contribute to us being sick. And so I am a chaplain, I'm a therapist, but I'm also have the opportunity now in my life to apply a lot of the science to that and to do more research, because as we'll talk about, I'm absolutely convinced that our field has not done a great job. So addiction treatment and mental health treatment, especially substance use disorder treatment, we've not done a tremendously good job of really researching and trying to understand what the problems are, what the solutions are, what works, what doesn't. And so right now in my life, though I do all the clinical work and all those things still, my real emphasis is that I get to really develop methods for researching and improving how we do the work we do.
That's great. That sounds extremely interesting, and what a great opportunity to be able to be engaged in that. So I know when we were exchanging emails kind of leading up to the episode, we were talking about exactly that, kind of how the Hanley Foundation is working to, do more of that work and addressing addiction as a public health issue. Do you want to speak a little bit more to that, John?
Absolutely. And this is a really, really exciting time for me. So like I said, I've been at Hanley for a long time, but the Hanley Foundation has the same name and the same family that started it all as the Hanley Center, but they've been two very different organizations for a long time. The Hanley Center is a place that is a treatment focus, right? So we have treatment for addiction and mental health disorders and comorbid disorders. We have programs where people who have illnesses can get well. And we have outpatient and residential and detox and mental health. There's all these different, but it's all treatment. Now, treatment is really, really important when you think about a public health crisis. And addiction I don't think that we even have to spend time going through all the statistics. 300 to 400 people will die today from overdose.
Staggering.
300 to 400 people will die tomorrow. So that's mothers, daughters, sons, husbands, fathers. That's people who they touch. It's not just that one number.
Yeah.
It touches all of the community. And so treating the disease is really, really important. But anytime you have a public health crisis, whether it's an epidemic or whether it's, and when I think of public health crises, right, you can think of addiction. Think about you and I, remember when AIDS probably, first became something that we would hear about in the news. And there have been many public health crises over the years. But when I was in my doctoral program at NOVA, we took a class on interestingly enough, in global epidemiology. And I had to the students, we had this section where we studied neglected tropical diseases, right? Stuff that, like, I'm thinking, okay, I'll study, it's interesting, but this has nothing to do with addiction. And there was a time where each student had to pick one disease and really do a deep dive on it. And I actually got stuck with the short end of the stick, which is another long story, but I didn't get the disease I wanted. I got a disease called dracunculiasis.
Wow. Never heard of
It's also
that.
known as guinea worm.
Interesting.
It's known as guinea worm disease, and most people haven't heard of it, but it changed the way I looked at what we need to do to address addiction. It changed my view of so many things. So dracunculiasis is a parasite. It's a condition where a parasite gets into people from third world countries, and it causes extreme discomfort, and it makes people, especially as it's exiting, it makes people unable to work. Now, that sounds to an American, that sounds like, oh, that would kind of stink. But to someone who, if you do not work, your family does not eat today, it's devastating. So this disease affected millions. There were millions of new cases in the world every year. Every year. When you look at, say, 1990, right? You and I were probably in school. So we're not going back, forever ago.
Right.
And today, or in 2022, in the world, there were 5 new cases. So all of a sudden I'm looking at this and I'm going, this disease that's been around for thousands of years and affects people, and there's no hope. Something changed. And what changed was Jimmy Carter and Rosalind Carter had a foundation, and they were in Africa, and they saw this, and they got a burr in their saddle. And they said, this is crazy that these millions of people are suffering from this. We're going to really put an emphasis to it. And what they did is they put principles of epidemiology and public health in place, and they eradicated it from the planet. The reason it had such a huge effect on me is because there's a model of dealing with public health crises that we know works. And when I then I started looking at other ones, and I looked at AIDS. And if you look at AIDS transmission in the United States, and you look at deaths from AIDS in the United States, and you look at first, it was skyrocketing. But then there's this bell curve. Something happened to make a change, and there are dramatic decreases now. What that does to me when I look at that and just see that on the face of it is I say if there is a way, if there are methods for attacking these diseases, then maybe we can actually apply them to addiction. And so as I began to study that, what is very clear, so the way there's an old model in epidemiology, and it's called the epidemiological triad. And it says when you're looking at a health condition, you want to change it or understand it, you have to look at the agent, the environment, and the host. I actually wrote a song about it, which I won't do on the podcast, but I'll sing it for you later. My kids know it really well. So the agent in AIDS, right? The agent is the disease, right? It's HIV. It's the actual, and so you have to understand that. And so you bring in scientists that can help you understand what the actual disease is. But then you look at the host. The host is who has it. And so we want to understand the brain. We want to understand what are the things how does addiction affect us? But really, really critical. And by the way, the thing that really changed in both AIDS and in dracunculiasis is environment. And we have, I would argue, an environment. So the environment is the family, but then it's the community, and then it's the nation and policies. And if you don't deal with, we spend a lot of time dealing with the host.
Yeah.
Right. So we're therapists, right? We detox, we treat, and this is necessary.
Right. But
our approach to addressing addiction and this problem in our country largely misses the environment. And so if you look at any successful public health attacking a negative health condition, right? If you look at any successful public health model, it's not just treatment, right? It's actually a really broad spectrum. So it requires researching the environment and the host and the agent. We have to understand, it involves prevention. So as we understand the disease and so prevention is one of the, if I can stop a disease or a health condition before it starts, that is the benefit to our society as a whole is incredible. But then also advocacy, because advocacy addresses the environment. Right now, to this day, right? And if somebody, I wish we had hours and hours and hours.
Yeah.
But I'd encourage anyone to really, if you're interested, look at the AIDS and study the things, the history of it in our country specifically, and look at when the bell curve turned. And I'll tell you when it turned, there is a correlation between the bell curve turning. That means people beginning to apply research to it. Initially, nobody would fund research. for AIDS. Nobody wanted anything to do with it. They didn't want to treat it. Why? Environment, public perception, stigma. When we saw the turn was when we saw really famous, well-loved people come out and say, I have HIV. And when we saw Hollywood essentially begin to make movies that influenced the culture. And then people began to put pressure on those who have the purse strings to invest in research and treatment, and it turned the tide.
Mm-hmm.
So prevention, advocacy, treatment that we do, but also, having ongoing community supports that continually support a healthy environment. All of these things are required to really truly address a public health issue like addiction. What jazzes me up and gets me really stoked is that with the foundation coming together with Hanley Center, now it's this one organization actually it has strong arms promoting and working in all of those areas. It's a really unique opportunity. It's a really unique place to be. So we have a vibrant prevention. We're actually the largest provider of prevention services in the state of Florida.
Oh, wow.
And it's all over the place in rural locations. But I got, it's interesting when you talk about prevention, there's a lot of different opinions. And one of the things that I hear people say, is prevention doesn't work, right?
Mm-hmm.
You can't get kids. You're not going to convince kids. Kids are going to do whatever they're going to do. People are going to do whatever they're going to do. Prevention doesn't work. And it is absolutely not true.
I agree with that.
A true statement is bad prevention doesn't work.
There you go. That makes sense.
Because there is a lot of history, and we'll need to mention it, but we're all aware of, times where people have, especially in the 80s and the 90s, really, there were these big pushes, these prevention to prevent kids from ever using drugs and they were, most were epic failures. Mm-hmm. Some actually have been studied and demonstrated to have probably contributed to making the problem worse, making kids more likely to use, right? But those were not based on research. They weren't based on science. They were based on people just thinking, kind of like the scared straight. Like if I yell at a kid and tell him not to use, he won't use. But just one tiny example of prevention that's happening out there that is what's called an alcohol literacy program. So they're going into high schools, and they're not going into high schools and wagging their fingers and saying, if you drink, you're going to die and this and that. What they do is they've done research and see what actually decreases the likelihood that a kid will start drinking. What we do is we teach them about how marketers work. Mm. We show them commercials. And they say, we're not here to tell you, we're going to give you some facts about alcohol and things. You can do what you want with it. But what we do want you to do is be literate and to understand what you're seeing when you see commercials. And so they actually teach the kids how commercials are trying to trick them. And it is brilliant. Mm-hmm. And the kids are into it, and it's been demonstrated to decrease the likelihood, because what we do is we now come in and we say, we're not going to yell at you and scream at you. We're going to say, hey, guess what? Someone's trying to trick you, and it's not okay. Yeah. And we're going to show you how, so that we're empowering you. That's just one example of prevention that works.
That's just hearing you say that, what came up for me is how helpful that information was. And I don't think I was introduced to that information until like undergraduate psychology. I think the class was probably like, psychology in the media or something like that. And we did exactly that. Right. We looked at various samples of, commercials and things like that, and learned a lot about, the power of influence and like how the media, how they were designed to do exactly that, to persuade, to, influence individuals to purchase products or to change opinions and things like that. But that didn't happen until I was in undergraduate, right? So to be able to have the power of that information at a younger age, I could imagine could definitely make a lot of changes with those people.
Right. And that's just one of several examples of prevention efforts that are out there, that are effective. So, I mean, that could roughly, in the United States, estimated somewhere around 170,000 deaths per year are alcohol related, one way or another. Prevention, if we can decrease, first of all, if we can increase the age, if someone's going to start drinking, if we can have them at least delay that, then the likelihood that they're going to develop the disease is significantly decreased.
Absolutely.
And we can, just through prevention, have an impact on that 170,000 unnecessary deaths, and we can bring it down. In treatment, obviously, you and I have, I have the greatest respect for you. I think you're the work you do with, I've seen the work you do as a treatment provider and as a therapist. And I've talked to the folks who you've treated, right? And I know that you're one of the guys that does it really, really right. What we do is really important. That's valuable, but it's only one part.
Yeah.
And
it's true. No, go ahead.
Even with that one, we can and should be constantly researching how to do treatment better.
Absolutely.
It's so common for people to have a one size fits all kind of, mentality. And what the research is showing more and more clearly is that the treatment needs of a person with a substance use disorder, they're not, it's not easy to just put them all in one category. Some people need residential treatment. Some people need detox, but not everyone does. Right. And so there are, our field, I think, and I've certainly done this and been part of this, has tended to really rest on, well, this is what this is kind of what was established as addiction treatment, 30 years ago, 20 years ago. And so we're resting on that. But would we ever be okay if that was true for cardiologists, right? Or any other specialty, right? So research, and that's is always been a passion of mine. But when the foundation came in, I really now have this opportunity to have a research department. One of the coolest things is that Hanley Foundation has just established its own federally registered institutional review board. So which I don't know that I don't think any treatment center that I know of in the country has one. This is normally a hospital or a academic institution. Right. But what that does is a mechanism where we can really do, research at the highest levels, where we can assure that we're doing it ethically and that we are protecting the rights of everybody who's involved in that research. But research isn't just like something for fun, right? Research has a mission, and the mission is people are dying. Even when people who get treatment come into treatment, some of them live because of it, and some of them their disease continues to progress, and their outcomes are negative. What's at stake? And you know this, and probably people listening to this, probably everyone knows this. What is at stake for every single patient is enormous. We speak to the families. It's not just that person. And so we really have an opportunity to put constant effort into looking at what we're doing, what's working, what's not, and how we can improve it so that more people can get their loved ones back.
Yeah, I couldn't agree with you more, John. And then, as we're talking about this, what comes up for me is, we all know the biopsychosocial spiritual model of assessment and diagnosis and treatment and all of those things. And to your point, and we're not throwing shade or anything like that, I think, previous kind of treatment approaches, maybe we were just kind of doing the best we could with what we had, right? Or what we knew, or what was kind of passed on to us about like, hey, this approach works. And, it's refreshing to know that people are starting to come around to the idea that like, maybe that doesn't always work, or maybe we need to be more creative. And as you mentioned, we need to understand more clearly about the epidemiology and like what the causations are, where these things are coming from, what's going to work best for the individual person and not just for the demographic as a whole. And to your point, I think, the biopsychosocial spiritual model still applies, but I think how we look at it, it's not just, shouldn't be, I guess, in my opinion, is not just a way to assess, where a person has come from and where they are now. And then all of a sudden we just throw them in this box of what kind of treatment they're going to receive and they're just going to get better from that. Like that just doesn't work, right? And I think we see it more pronounced these days that individuals are more complex. Our problems that we're facing are more complex. Society and the influences that society has on us and how we engage with the world around us is more complex. And I think our treatment approaches need to be more complex and individualized and focused on how we can understand, of course, where that person has came from, what's influenced, where they are now, but then trying to take a truly individualized approach to like, what's going to be best for this individual, right? What kind of treatment approaches? How can we engage the family? How can we provide education and move them in a direction that's going to truly be effective for them and not see these individuals just get caught in this cycle of, receiving this, out of the box treatment that just continues to not hit the mark, unfortunately, sometimes time and time again, right?
I couldn't have said it better. That's perfect. And I can even think of it myself, right? And I'm with you. Every one of us, no matter what, if somebody is in this field and they are doing their best to help people and they're being ethical, I'm on their team.
Right.
I'm with you. It is, we get, critical of it. The reality is I think of things that have changed in me, right? So that biopsychospiritual model it is who we are, right? We are body, mind, and spirit.
Absolutely.
But I can think of, when there was a time about 15 years ago, I was the clinical director of Hanley Center, and we had and I was at the time, so maybe 16 or so years ago. I'm a single father with 2 young kids. I'm the clinical director of Hanley Center. I was an adjunct professor at the State College. I was this busy guy. And we had a psychiatrist who was really well known, and he came here and he was giving a presentation, and he'd gotten to know us for a little while, and I wanted his feedback and what he thought about us. And he said, "John, you have much to be proud of. You do very good treatment here. But if you don't stop feeding your patients crap, they will never get better." His words.
Wow.
His words.
Okay.
Guys, that was Dr. Daniel Amen. And he was, and it jolted me. Well, you know what? I'd never been trained in I'd never thought of nutrition. At that point in my life, I never looked at a label. Right.
Okay.
And so that feedback began a journey here at Hanley Center, where today we have where we changed everything, where we brought in a chef, and actually went from having food that was brought in every day to completely rebuilding our facilities so that every single thing here is fresh, and that we can control what's the nutrients that we're putting out there. Because what we now know is that the connection between our nutrition and our brain and our mental health is significantly stronger than the connection between medications and our mental health.
Yes.
It's and the research is, so we integrated I took a year-long program in nutritional psychology, and we integrated a nutritional psychology program here at Hanley. And we brought in nutritionists. But I was doing my best. I was, which a lot of people are with the information they have, but I was faced with new information and new data and new research that I had to, it was my ethical obligation to incorporate it. It's ever growing. Our team is constantly studying what are the foods that will actually specifically help the brain heal from addiction, an acute state in this residential setting. So it's a constant search. We could think of many.
Oh, yeah.
Actually, I'm a guy who's had many of those moments. But the point is that I think that we have to approach this with this, looking at it from all those, the agent, understanding addiction, understanding the host, and the person and what happens to the person and how people get well, and also the environment. To me, you mentioned family work. So as in my role, I'm really, really lucky, right? In my opinion. So I get to, one of the ways, the innovation part of what I do really is by, my job is to understand the research and the things that are working out there, and to create and grow and contribute to new programs here. The way I personally do that, if I'm going to, help design a new program, I'm going to do that new program, right? So if I'm going to design a sports therapy program, I'm going to jump in and be the sport, and family work has always been really, really important to me. Yeah, one of my masters is in marriage and family therapy, and we do a lot of family work here. So, if a patient is in residential treatment, we have families come in, they fly for a 5-day program. It's transformative.
Yeah.
So you have to address that family. But what I found is that families are needing more. So, someone actually, years ago, before I studied marriage and family therapy, I was here and somebody suggested to me, well, that family program's really great, but you don't do marriage and family therapy. You don't actually do family therapy. I said, yes, I do. He said, no, you don't. It's really good what you're doing, but it's not family therapy. And as I began to, I was challenged. I had to grow, and I learned, guess what? It's not family therapy. Family therapy is something that actually is working in the one single individual system. So we put in, but the need is clearly there. So we now have a program called Family Lab, where families, whether inpatient or off, by Zoom, and it's actually now, if they finish our family program, they can elect to be part of this Family Lab, where they get a couple months of weekly family therapy sessions that are recorded, and they are reviewed in clinical supervision with a PhD in marriage and family therapy, who's a known expert. And so it offers both these families get actual family therapy, but also it's become a teaching site for therapists who want to get better at marriage and family therapy. Not every therapist has that training or experience.
That's very true.
The bottom line is that all of that has to come from, if we are not humble, if we're not able to say, if we're not able to hear the feedback, if we're not able to hear that if we just rely on this is what I was taught to do from somebody who was really, at cutting edge 40 years ago, then we're not gonna ever improve, and we have to improve.
Yeah. Yeah, I couldn't agree more. And that's amazing. I mean, that you guys are doing that and that you have the ability to do that. I mean, that is great work. I'm so happy to hear that, John. And to your point, I think feedback, right? It's such a valuable gift. And to your point as well, that you can't receive that even if you hit those, you receive those bits of feedback that are sometimes really, really tough to kind of take. They are an absolute gift, but you do have to have that humility to be able to hear that, to be able to incorporate that, and to ask yourself the question of, okay, what can I do better? How can we make this better? So I couldn't agree more, John. I think the feedback is a huge gift. And, I tell people all the time, right? Whether it's a family member, whether it's a client, whether it's a staff, a team member, I'm always very open about, like, if you have feedback, like, I want to hear it so badly. I want to hear it, even if it, rocks my core that, like, oh no, this means that we're not doing something well. I'm going to take that, and we're going to do anything that we can to try and improve in that particular area,
100%.
Yeah.
And that same thing will, I think about being in this part of this foundation right now, right? And I've got, we've got all of the arms. I mean, everything to really make a difference. But I don't think that that's the only model. In fact, I know that's not the only model that can do that, because the reality is there are all of these. There are prevention programs and treatment programs. There are advocacy groups. There are community support groups all over the place.
Mm-hmm.
Where humility also comes in, and this is where our CEO, Dr. Rachel Driscoll, has given me a very clear mandate, and the mandate is give it away. If whatever we have, we share. Mm-hmm. Whatever we learn, we give away. And that, to me, is key to this, because our tendency is to really isolate and actually have competition. Isn't that a crazy thing?
It's so frustrating.
Isn't that just a morally gross thing? Competition in healthcare?
Yes, I'm with you. And it goes back to the point that you made earlier. I mean, if we want to affect change, we can't remain siloed and not, give away our quote unquote trade secrets, right? Like, that doesn't help the world that we live in at all.
Right.
Yeah.
Right.
Yeah.
And there are no trade secrets.
Right. There's not.
There are people who I don't know, might make somebody mad right now. I think there are people who think there are, but there's really nothing new under the sun.
Yes.
Except what we find in research, and you want to publish that anyway.
Right.
So I think that, there are people who are going to listen to this that, might say, well, shoot, I've just got an outpatient over here, or I'm just, I've got, I'm like you were just doing treatment, or maybe I'm just doing prevention. Mm-hmm. But through the building of relationships, if we will build relationships and partnerships, the same phenomena, we can have unthinkable a number of organizations and places and spots around the country where all of those things that are needed to address all three of those issues in the triad, right? The environment and the host and the agent, it can really come together. And so I think that relationship building and not relationship building for the I don't want to, there's nothing wrong with marketing, and there's nothing wrong with letting people know what you want, what you're doing, right, and that thing. But relationship building for the purposes of joining forces to get people better, mm-hmm, to be better at what we do. That is, I think, it's the future if we're going to really, really make a change.
Completely agree.
So I want that, I'm with you. I want that feedback, and I want that feedback from you, and I think about those two people who gave me feedback I didn't like to hear.
Sure.
I I'm the clinical director of Hanley in my, this is quite a while ago, and I'm feeling good and feeling very proud. And I got knocked down. And I love our family program. It is incredible. It is amazing. And if you work in there, there's a pride and lives are changed. And this guy comes along and says, you don't do family therapy. and it was like, oh, but both were really, really, really right.
Yeah.
So you're right on. We have to be open to that feedback. And that's, fortunately that's our culture. I get to exist in a culture where that's part of it, there's not a fear, there's not a fear of failure. Our CEO will say, she says, come fail with us.
I love that.
At first time I heard that, I went, there's something to that. And so, I get, when somebody calls and we'll get this, somebody will say, look, so for example, we have and again, there's so much, measurement-based care is a big, big part of what we do that we didn't used to do. Right. So, I would say, man, we do so great. And I'd get challenged. Prove it. How do you know? Well, I see it. Okay. Why should I trust you? Where's your data? How do your patients know if they're getting better? Well, if they feel better. Right. But is that it? Just how they feel? So when they have a bad day, are they not getting better? Are you actually measuring and having them measure on a regular basis their progress? If they have depression, do you measure the severity of their depression, the anxiety? And the answer 10 years ago was no, we don't do that. Well, today we do. And we have a very robust, rich program for that. And if somebody I've had 3 or 4 organizations over the past few years say, how do we do that? How do we implement that? And man, I think give that away. Because guess what? When I first started to look at this problem, I said, who do I call? And, somebody said, call Nick Hayes up at Cumberland Farms. And I called Nick Hayes. He's their chief science officer, not Cumberland Farms, Cumberland Heights.
Heights. Okay. Gotcha.
Sorry, guys.
Yeah.
and Nick, got on the phone with me and said, start this way. And I started this way and it grew from there. And he didn't say, well, I can't tell you.
Right. Exactly. Because that's not helpful. It's not helpful. I mean, and to your point, I think we all need to find ways. And again, I think it is refreshing. We do see some changes in the field with that, right? It feels that way to me anyway. People are collaborative, becoming more collaborative. People are more willing to kind of, help each other out. And we do want to expand, just the access to knowledge and how we can do things better. So it feels good. John, unfortunately, we're coming to the end of our time. Man, I have really enjoyed this conversation, man. It has been a lot of fun.
Me too.
It's been cool.
Me too.
If you're open to it, I think there's probably a lot more we could talk about. So we should definitely do this again in the future.
100%. Can't wait.
Yeah. So we'll make sure, we put links and everything like that in the show notes so everybody knows where to find John and where to find the Hanley Foundation. I will, again, in full transparency, definitely some bias here, but Hanley Foundation, the Hanley Center, multi-program residential facility with different levels of care as well, down in Palm Beach County, Florida. They do amazing treatment. I mean, New Waters Recovery, we refer there all the time. And we do that because we know that when we send clients there, they're going to be really cared for and they're going to receive some top-notch treatment and with wonderful individuals at the helm like Dr. John Dyben. John, we appreciate you, man.
It's great seeing you again.
Good to see you, buddy.
All right.
Take care.
We'll see you next time.